sports and significantly less time compared to open repair. Patients also reported less symptoms such as pain in limited open repair, according to the JS reviewers. Again, there was no difference in re-ruptures between the two techniques, no difference in complications, major complications such as DVT, large hematoma, ankle stiffness, insertional tendinopathy or deep infection. And the limited open group was found to have fewer severe wound infections, superficial infections and minor infections than those treated with open repair. They commented on graft augmentation in Achilles rupture, use of allograft, autograft, xenograft, synthetic tissue or biologic adjuncts, and found that there were 4 studies that found that there was no improvement in outcomes, so that the recommendation to use them was really inconclusive. I can't recommend either way. So it's come up early. With regards to DVT prophylaxis, again, there was a systematic review conducted and couldn't find any studies that addressed the issue of DVT prophylaxis specifically in acute Achilles tendon ruptures, and so therefore they cannot conclude either way whether we should use DVT prophylaxis routinely. Early postoperative weight bearing. This is one of the suggestions that they can make some recommendation. They suggest early, less than 2 weeks postoperative weight bearing, including limiting dorsiflexion for patients who have undergone surgical repair. And this is based on 4 level 2 studies comparing cast immobilisation versus early weight bearing. 2 of these studies looked at weight bearing in a cast versus non-weight bearing in a cast. 1 study looked at immediate rehab in a splint versus cast immobilisation. And 1 study looked at weight bearing commencing 2 weeks post-op compared to cast immobilisation, non-weight bearing. So the weight-bearing group overall had a faster return to activities, work, sports and walking, better physical functioning scores and fewer limitations to daily living at 6 weeks post-op. However, at 12 months there was no significant difference in outcomes between early weight-bearing and non-weight-bearing groups. This was seen as a moderate strength recommendation. Post-operative splinting. They suggest the use of a protective splint if you're allowing mobilisation, to restrict dorsiflexion. This is addressed by 5 level 2 studies. The studies looked at a cast for 6 weeks versus early motion in a modified splint that just limits dorsiflexion to protect the repair. And the studies found an improvement in the mean time to return to work and walking. One of the 3 studies found a higher return to sports at 12 months, but 1 study found a higher re-rupture rate with the mobilisation group, 9% versus 0%. However, this is only based on small numbers, and both patients were non-compliant with their treatment and had a fall within 4 weeks of the surgery that caused the re-rupture. There was no difference in pain and functional scores after 12 to 18 months between the 2 modalities. So this recommendation was seen as moderate. I do suggest early mobilisation in splint. Post-operative physiotherapy. Again, they couldn't find any studies that specifically addressed physiotherapy versus no physiotherapy, so they were unable to recommend for and against, and they found that inconclusive. Resumption of ADLs. Again, they couldn't recommend a specific time which patients can return to activities of daily living. Despite having 18 level 4 studies that investigate this, there were differing results with high heterogeneity, and they were unable to draw any specific time. Again, seen as inconclusive. Return to sport after surgical repair. Patients who have undergone surgical treatment, it's an option to get them back to sport within 3 to 6 months. There have been 23 level 4 studies looking at this. 2 studies said jogging after 3 months. 1 study said return to sport at 4 months. 5 studies said 83 to 100% have returned to sport at 6 months. And 11 studies have said 32 to 100% return to sports at 12 months. And these aren't random AFL players, these are two high-profile AFL players that have ruptured their Achilles and then returned to sport. However, they do say that this recommendation is weak because of the level of the evidence. And return to sports after non-operative management, again, they can't recommend a specific time. There have been 5 level 4 studies with variation in treatments, variation in reported outcomes, and they can't draw conclusions. And hence this recommendation is inconclusive. So to conclude, they've said that there has to be a lot more further research, especially high-level evidence with regards to Achilles tendon ruptures, especially where they've graded can't make a recommendation, it's inconclusive, or the recommendation is weak. In particular, more randomised trials investigating surgical versus non-operative management, high-level studies investigating the power of MRI or ultrasound in diagnosing tears, and immediate functional bracing in non-operative management. Very much.